Welcome to Kidney Cancer Unfiltered. I'm your host, Anna Maria Scaccia. In this episode, we're joined by Katie Coleman and Dr. Pavlos Msaouel to discuss the challenges of being diagnosed with kidney cancer at a young age. Katie shares her journey from feeling intimidated by doctors to becoming an informed advocate for her own health. Dr. Msaouel explains why sharing research and experiences is vital for better outcomes. Well, thank you so much, both of you, for joining me today on this episode. For the listeners who may not know both of you, could you please give your introductions?
Yeah, of course. Thank you for having us. My name is Katie Coleman. I am a stage 4 kidney cancer patient and survivor. Was diagnosed in the end of December of 2020. And so now I kind of focus a lot of my time these days on advocacy, as well as I work at the Rare Cancer Research Foundation as well, too.
And I am Pavlos Msaouel. I am a physician scientist at the University of Texas MD Anderson Cancer Center in Houston. I run a lab, see patients, and design clinical trials for kidney cancer with an emphasis on the rare and aggressive ones. And very happy to be here today with you guys.
Well, thank you for joining us, but I'm so grateful for you to join us to talk more about your story, how you guys have connected, and basically what, where you are now. I think, Katie, what I really want to start with is we know that your diagnosis was delayed for a lot of reasons. How did that delay in the diagnosis affect your physical and emotional well-being?
Yeah, wow, there's a lot to unpack into that question all into one. But there are a number of things that kind of led to the delay in my diagnosis. And so it took about 1.5 years of me pursuing various symptoms. And I think that there's a number of different things when I think back of that period of time. I was very young. I was 29 when I was diagnosed. I was like 27, 28 as I was pursuing some of these symptoms. And there's everything from how I was presenting in these appointments. Like I was nervous. I was very intimidated by doctors. And so when I had a long laundry list of symptoms that I was trying to present and work through, it's overwhelming to present those, but also sometimes like I didn't stand behind my convictions, I think, sometimes to know how to advocate for myself and continue to push harder on certain things. But I also think sometimes it's just hard to know, especially like what was a symptom directly for me versus what was not. And so some of that kind of delayed the process of getting diagnosed. I ultimately ended up getting diagnosed once I could actually feel the tumor in my abdomen. And that came after about 50 pounds of weight loss. It ended up being found when it was felt in an urgent care. And then they sent me to an ER to get it looked at because they thought it could have been a large liver. And that's ultimately where we ended up finding it. And so during that period of time, I knew something was off. I didn't know how to describe it. And that was kind of part of the difficulty in presenting my symptoms. I know there was a period of time that I was presenting all these symptoms. I was trying medications to lower my heart rate, lower my blood pressure, all of these different things. I had severe lower abdominal cramps that I was dealing with, and any solution kind of wasn't. Any of the medications weren't helping that much. I did have one that eventually lowered my heart rate a little bit, but I kept feeling like something was wrong. And I asked several different physicians during this period of time, like, could we rule out cancer? Because being diagnosed so young, I also I was so naive to the medical system and cancer in general that I didn't even know that there's not one universal test that you can run to rule out cancer, right?
Yeah.
And so feedback when I usually was asking those questions was from several different providers was that I was too young for cancer and kind of just needed to get a handle on my anxiety. And I think a lot about that. That actually ended up being the title of my book, because when I did get diagnosed in the ER, that is what looped in my head, was like, you're too young for cancer. And there was just this, how did this happen? Like, I knew something was wrong with my body. How did it get caught so late, to the point that I was stage 4? And then the kind of layer on top of that of kind of how that has impacted my care further, and maybe we can dive into different conversations and touch on that. It's a much greater piece, but that made it much more difficult for me to navigate the medical system after that, to trust again. Like, it took a while to build up the trust. And it led to me asking a lot of questions. It led to me advocating and pushing really hard in different areas, which I think benefited me in some areas, because I had such a rare cancer and really needed to learn how to advocate for myself. But it did ripple out to the rest of my care as well, too. And it took me a really long time to build back trust, to be able to trust treatment plans and everything like that. And Dr. Msaouel, I don't know if we actually mentioned it at the beginning of the podcast, but he is my oncologist as well, too. And like, he was instrumental in helping build some of that trust back for me as well, too.
Thank you for that answer. I wanted to start there. I know it was a heavy one, but I wanted to start there because I want to dig into that too young for cancer, right? Like, even though my experience is 100% different than yours in terms of like stage, type, and whatnot, I heard the same thing, right? When my urologist saw me, he was like, well, you're too young. You don't fit the profile. Like, you do not fit the profile. And if it wasn't for my PCP looking at my kidney labs and saying like, okay, you should not have any of these labs, I probably would not have been diagnosed. So I wanted to ask you, doctor, like, how can doctors improve their approach to diagnosing rare conditions or just conditions in general when a patient doesn't fit the typical profile? And I guess to that question, sorry, before you answer, I guess to that question, how do you approach that, right? Because I know you've done a lot for Katie. I know you've done a lot for Heather Williams, who we also interviewed on the podcast. So I would love to get your perspective, both for yourself as a doctor and also for the community too.
Yeah, and that's one of the challenges, because in many ways my approach is biased, in the sense that the patients that do end up seeing me have almost always already been diagnosed with kidney cancer. And I do specialize in the more unusual types of kidney cancer even more. So a lot of the patients that I do end up seeing are like that, and I am mindful of that. There are all of these trade-offs. On one hand, you got to keep an open mind. It's not always in your head. I've heard it from a fair number of patients who were diagnosed young with cancer, because those are the ones that I end up seeing, that I just felt they say that there was something off with my body. And it's very interesting, because it seems to be a common pattern. And I don't think that many of them have talked with Katie. And yet they are saying that same thing, that, for months or even years, I just felt that, something was off. And some of them may even be associated with the healthcare system. So they may themselves have had this hesitancy. And at some point, they're like, you know what? I'm just going to do it. I'm just going to, get this imaging, this CT scan, this MRI, and they end up finding the tumor. And everybody is asking, how did you guess it? It's just, sometimes it may be a good idea to listen to that gut feeling. On the other hand, I can certainly understand the hesitancy, from the PCPs who are in the front lines, where, they may be getting a lot of people who may be having these complaints, and they end up, there is nothing there. I think that there is a lot of training that should go into how can we distinguish between the two. And I think that one of the important things is persistence. You talk to somebody like Katie. Okay, Katie has her act together. I mean, you talk to her enough, you get it. Like, she may have, she may get anxious, as we all do. I mean, I would get anxious if I had this. But you can tell that this is a person that is coherent, is giving you a list of specific things. That's what she keeps doing, because very often she talks to me about, hey, could this have recurred, or could this have happened? And I could approach it, in a dismissive way as well, same as, a PCP, and say, that's nothing. But you can tell that what she's saying is coherent. There is something to it. And I would say that can be a signal to say, perhaps in this case, I can go a little bit beyond the standard guidelines and do that extra thing, because I know that, that information is going to be digested in the proper way, because many PCPs may be afraid, then I might find something, and then it's going to take you down a rabbit hole that can be dangerous. But I think that if you trust your patient, often, you can escape these kinds of thoughts and proceed with, gathering that information.
Yeah, I think I want to touch on the hesitancy, and I'm going to throw this to you, Katie. So with advocacy, you've been very, I guess, vocal, right? Like about patient advocacy for yourself, really inspiring other people to do it. But there sometimes are people who know that they should be advocating and should be strong enough to advocate, but there's still that hesitancy. For me, in my case with thyroid cancer, it was very hard for me to advocate for myself with my surgeon, because I was in such a hard mental space. But we know this, obviously we talked about this, but he was very much like, no, I'm the surgeon, I know I got all the cancer, you're good, I'm not going to check anything. And then it turns out I still have it. I guess, one, how did you approach the hesitancy that you felt, right, when you were advocating for yourself? And how can other survivors and patients kind of push past their own when they're trying to advocate for themselves?
Yeah, this is such a complex topic, because I also will say I do a better job helping tell other people how to advocate for themselves than I do advocating for myself sometimes. And I'm actually really glad that Dr. Msaouel brought up some of the communication that we've had, for example, because I think this entire topic is really complicated when you talk about how do you advocate for yourself? How do you differentiate between when something is right or when something's wrong and when something's okay? And I think that's a really hard line, because they're before leading up to my diagnosis, I knew something was off, something just felt off, right? But there's been plenty of times that I know you and I talk about things, or we especially did earlier in our diagnosis as well too, of being worried about reoccurrence or different things. And there's been times that I've had symptoms or things that didn't feel normal, and I've messaged Dr. Msaouel to let him know. And whenever I approach those things for advocating now, when you talk about how can patients advocate for themselves, for me, the thing that I felt like I always did wrong, and it's hard for me to say that I did wrong, because I think that puts blame on patients, which I don't think is right, because none of us know how to navigate these systems until you are in it, trying to navigate your own healthcare. But when I was initially diagnosed, the thing that I really struggled with is I would present with symptoms, and then I would take the questions as an evaluation of my character, not an opportunity to add clarifying detail. And that is where I think it really pivots for me. And if there's a question that comes back, it's not necessarily no, this is the way it is. A lot of times it can be okay, maybe you need to add some context here, help explain why the thing that you're feeling is different and contrasts with that. And so for me now, whenever I do try to present things, I try to I rule out kind of all the things that I thought it could have been, provide detail to that, and then just try to provide as much detail as I possibly can. But it is tough, because there's plenty of times that I've been worried about something and there wasn't something, right? And so I think the best thing to do is to be able to keep track of like, especially your own symptoms and things that you're having, like know the frequency that they're occurring, try to find ways to describe them. It can be so hard to try to describe some of the things that you're feeling sometimes, but see if there's a consistency to it. For example, like the difference between feeling dizzy and lightheaded, and like trying to tease out as much of that as you can to prepare for any questions that you might be able to have so that you can fill in with clarifying detail in there is kind of my biggest recommendation that I would make for it. But I will say I do a much better job of helping others advocate for themselves than I do myself as well too. So I can definitely relate to the feeling that you had, for example, with your surgeon.
Yeah, I think when it comes to ourselves, it's like, yeah, it's just those who can't do teach kind of situations. Maybe that's not the right cliche for this situation, but I just kind of think of it that way. Um, so I think in terms of being like too young for cancer, which I do want you to talk a little bit more, and we could do that now. I would love for you to talk a little bit more about your book and your memoir that's coming out in November.
Yeah, so I wrote that. It's coming up on 2 years since I started writing that. And you're actually in the book in a short piece as well too. I think that all kind of ties back to kind of why I wrote the book. When I was initially diagnosed, I started sharing on social media immediately, and that's how we ended up finding each other. I share a part in the book of like where I hit one of my lowest lows. And I was really struggling, and I was struggling in a way that the medical system at the time couldn't help me just because there was like delays in like when I could get in to see a therapist, right? Or when I was going to have my first appointments. And I discovered the network of support groups, and you and I found each other, I think,
Yeah.
either through Kayla or through like Instagram hashtags.
All of it at the same time, I think, really.
Yes. And so there was this like community of support that kind of helped fill in and helped fill that kind of emotional gap that I was really missing to try to help me get through those early days of my diagnosis. And when I thought back to when I was initially diagnosed, like so much of my fear came from I was 29, I was a newlywed. I had no idea what to expect, but the only thing I knew about stage 4 cancer was like what I saw in books and movies and TV shows, which wasn't great. And I had never known anybody that had stage 4 cancer personally and just had heard from when people passed from it. And so I didn't have any context for what that was going to be like. That motivated why I started sharing online, is hoping that like I could provide. I had no idea how it was going to go. Thankfully, it's gone pretty well so far, but um, hoping that could give somebody else a little bit more information than I had. It was even things like I had no idea what an MRI was going to be like, CT scan, any of that was like. And so when I wrote this book, I really wanted to focus on that. I wanted to focus on what all the feelings and emotions were happening that were happening behind the scenes that didn't get shared on social media, that weren't necessarily seen. Like I share a lot of interactions I had with physicians. We were talking about like, how did my diagnosis before lead up to how I interacted with the medical system after? It was these very small, like 30-second interactions in many cases with everybody from physicians to phlebotomists, that I share in the book of like times that people took a second to show a moment of empathy and connect on just like a human to human level that really helped change my relationship with the medical system as well too. And then that rippled out to advocacy as well as the support groups and everything like that. And so I wrote this book to be able to help other patients, hopefully, to be able to see like you're not alone. I share very honest and real thoughts that I had, and the emotional struggles that I had early in my diagnosis, and then also to share the other side of that, and kind of what can change when you do advocate for yourself in the healthcare system, as well as the impacts that even just like the smallest moments from those in it can have on patients. So that was kind of my main motivation behind writing it. And it comes out in November. So just a few months away, but pre-orders are available now as well too.
Yeah, I pre-ordered it. I think the minute that you shared with the group that it was ready for pre-order, I'm like, okay, let me go do that. I'm very excited to read it. But I wanted to turn to the doctor, Dr. Msaouel. Now, when you first connected with Katie, like what were some thoughts that went through your head in terms of helping her with her treatment, figuring out what the future would be in terms of, following her? What was kind of your experience? Can you explain one, the rarity of her cancer, and why it was difficult to diagnose it? All the background around that.
Yeah, so at first, key thought is that her case is exactly why we do what we do. This is it's in the really really challenging cases that one can make a difference. And it was what Katie has is a cancer essentially that per the textbooks is not even supposed to exist. So, in this stage having stage 4 metastatic oncocytoma. And so you will see it even in many academic centers. People will say, even experienced, kidney cancer physicians, that, oh, no, that's not even supposed to happen. And so there is only a handful of such cases reported. Now, thanks to Katie's efforts, we know more even about such prior cases. And I think that, her case itself is going to be in the public domain, written and shared now with the academic community so that we can all learn from it so that people in the future can be helped. But at the time, this is completely uncharted territory. So whenever you're dealing with something like that, there are two ways to address it. One is say, oh my, this is not in the textbooks, I don't know what to do. Or the other is to say, hey, if you think about it in a certain way, every single thing that we do in life is uncharted territory, like every single thing. So, what are the guides that we use to navigate through life? Well, let's use those to address her case. And so what is it? We see patterns. As human beings, our minds are evolved to see certain patterns, to see certain commonalities. You dig deeply enough, you will realize that those commonalities don't exist anywhere. Mm-hmm. But somehow our minds are capable of finding certain patterns that work. Mm-hmm. And so take that strategy now and apply it to Katie and say, hey, her cancer is in theory very, very, very unique, but in a way, every person's cancer is unique. Like every person have their own, genes. Their cancer has unique genes, 100%, compared to somebody else. They have their own values. They have their own environment, as people, etc. So there is uniqueness to everyone. So you find commonalities with other cancers that may be more frequent, and in her case, that would be chromophobe kidney cancer. And you justify in a coherent way what are the connections and what would make sense. So that can help guide you with regards not only to what could work, but also to what has low chances of working. And the other guiding principle when we navigate through life is collaborate. So, we are social beings for a reason, because, we cannot be islands into ourselves, just doing everything. It has, you have to find the right network of people, the right network of scientists, physicians, etc., to help tackle this case. And I think those were key principles that definitely helped us here.
I'm so glad you brought up the uncharted territory comment, because I often think about conversations I've had with doctors or scientists about certain other things. And there's always this comment of, well, we don't have research, therefore there is not this connection, or we don't have research, therefore it does not exist. And I always, it's a probably a silly thing for me to think, but I always think in my head, like penicillin wasn't a thing before, until it was, right? Like, and so what would your advice be then to other physicians who kind of face these? I mean, you gave a little bit of those like key principles you used in terms of Katie's case, but generally, right, more broadly, what advice would you have for other physicians who may be facing things that maybe there's a semblance of a connection there, but there's not research on it, in terms of keeping that open mind and pursuing more?
Push. Don't get discouraged. Just push. Believe in that a difference can be made. And again, there is this complementarity whereby I mentioned we are social beings. We need the interaction. It takes a village. But at the same time, you also need certain key people that will champion things. And that includes both the patient advocates that need to champion and physicians and scientists that need to champion. So I would very, very, very strongly say that such championing makes a difference for rare and common cancers. We're literally, we're talking with Katie about this. We just published data in this very, very aggressive, very deadly kidney cancer that is, a passion of ours called renal medullary carcinoma, a kidney cancer that last week I heard once again that it is supposed to be unbeatable. And this was, a good example. I was having this conversation with what we call a peer-to-peer physician. So these are the physicians on the other side of the line who, represent insurances. And it's a very common thing to dislike them because, they are blocking, what we want them to do. And, with renal medullary carcinoma, that is also an uncharted territory. We have been able to develop and champion research that is truly making an impact for patients. And, we cannot even communicate it fast enough because we have accelerated research so fast that it doesn't get published, quickly enough, our knowledge, because there's a lag time between making the discoveries to putting them in the public domain. Takes about 1 to 2 years, which is why, I try to verbally communicate those things in conferences first and through messages, emails, or whatnot. So anyway, so that, oncologists thought that, renal medullary carcinoma is a death sentence. And so he said, hey, you know what, I don't want to offend you, but, I've been doing this for 45 years. I've been an oncologist. He's one of these grumpy, physicians. And I don't want to offend you, but this cancer is unbeatable. I saw one case, God knows when, and, patient died within 6 months and nothing we did worked. And so there are two ways to address this. You can get very argumentative, or, you can say, hey, no, data. Data actually can make a difference. So I started discussing with him. There is some data that Katie has now seen, and we just had them, presented in the social media as well. And as soon as I started talking about this guy got super excited. Like, it was such an amazing turnaround because literally for half an hour he could not stop asking questions. You get this person that has weathered through a lot of things and is very cynical, and now is acting like a child, with that enthusiasm. Of course, the therapy got approved, but it was just so fascinating. And so I think that we can bring that enthusiasm to many others, researchers, clinicians, other stakeholders, because differences can be made. We can see, cancers. We now have therapies for cancers that we did not have 10 to 20 years ago, but we're still not there towards completely eradicating cancer. Far from it. So there's a lot of work to be done, and that work is meaningful.
Well, I want to say thank you for being such a champion, not just for rare cancers, just in general for this research, because we need people, scientists like you, to really just go after it. And we also need patients or survivors like Katie, who are champion for the patient community. And I want to turn back to you because you're not only a champion for rare cancers, you're also a champion for young cancer survivors. And I just want to talk more about like the uniqueness about being a young cancer survivor. And I know that we had, if you haven't listened to season 1, go back and listen. We talked to a couple of young cancer survivors. But in terms of advocating, when you are, within that, I believe it's like 15 to 39 is what they consider like, AYA kind of cancer survivor. Just talk more about being a champion in that way.
Yeah, I mean, I think that there's so many complexities that come with having cancer at a young age. I mean, I think nobody wants to have cancer at any age, but while you're trying to navigate the decades of decision, and especially like in your 20s and 30s, there's a lot of decisions that are really hard to navigate while you have so much uncertainty in your life. And so I think that that is a big complexity of it. I will say that just want to pause for a second and kind of go back to what Dr. Msaouel was saying about presenting the data to that other physician. And what stood out to me is that we're talking about like the contrast here of like patient advocacy versus like advocating physician to physician, of like how much overlap there is between these things, right? And like the exact same process of like how a patient can advocate for themselves is the exact same way. So like how I had to advocate for myself for surgery to become an option, or for those conversations to shift, even navigating as post-diagnosis when I have new providers. Like I created a record, and that's kind of part of the Rare Cancer Research Foundation that consolidates all my medical records into one place, right? Part of that was because I knew people didn't believe what I had unless I had a full documentation of what it was. And I could explain why this wasn't me just thinking this. Like there's a whole bunch of data. There's some institutions like MD Anderson and NIH who have confirmed these kinds of things. And it shifts the conversation. And so I think that that's important, of like how much overlay there is between the two of them, and also that support comes on both sides. For example, if I didn't have Dr. Msaouel who helped teach me some of these things, who even just like going to MD Anderson or NCI of like, now there's going to be a case report on my case. That definitely doesn't happen for every patient. But those things are things that kind of can shift some change. But what I think that all ties back to in just patients with rare cancers, or if you have a cancer at a young age, I think there's a big overlap there, where a lot of times patients with rare cancers are oftentimes younger. There's also, I think, an important aspect to, you are now that rare situation in every kind of healthcare situation you present in, because you've had this rare occurrence already. You've had a cancer, and now you have to describe what that is, and be able to like carry that through. You also have to figure out how to navigate your life with the uncertainty that might be doctor's appointments or scans, or figuring out kind of how your prognosis fits into everything. And I think there's an importance in sharing that information, which is one thing that I think that the AYA community, the adolescents and young adults, does very well, or is advocating. Like we connected and caught, were introduced to each other. And without that community, as much as the systems existed, as much as my life was changed by getting to the right doctors, that would not have happened if this network of support from patients didn't already exist. It was other patients sharing their stories. Laura Esfeller shared her story, which connected me with Bruce, who had a nonprofit, Driven to Cure, that helped get me to the NCI, for example. As well as I connect with other patients to navigate side effects and treatments. There's this duality that happens, that I think patients offer a real support system for each other from like an emotional support standpoint, as well as a networking of support that I feel like is a little bit unique to young adults, is like we're navigating additional complexities of like, do you tell your employer about your diagnosis? Or how do you navigate PTO when you have to coordinate all of that for I need X amount of time for scans, doctor's appointments, and all of those things. And that's an area that I think patients are really positioned well to support each other in the adolescent and young adult community.
A part of me is like, that is probably a future episode, is like navigating cancer at work. Because I was just thinking about like my last treatment of radiation. I wanted to use my vacation time because I'm like, this is going to be the third time I'm on leave. I don't want to have to go through it again. I don't want to have to justify why I need it. And it is an added complexity. So we have to keep that in mind for maybe season 3. But I wanted to, for both of you, I think you're right. I have seen that with the young cancer survivor community. Advocacy is very strong, not just on the emotional, but like even on going on Capitol Hill and fighting for legislation and policy, and having those like patient advisor kind of councils. But for both of you, I wanted to get your opinion on how we can empower both more like survivors and physicians to be more of these champions, to be more of these like very vocal advocates. I think despite the young cancer survivor community having such a strong advocacy presence, there's still people who may want to get involved but may be scared. So how do we empower both physicians and survivors?
I think getting involved with other patients who are already plugged in is a really great way to do that. Like I know I've recommended folks to get in touch with the KCA, and I know that like you've done podcasts with a couple folks that I think are coming up that will either air before this podcast or after. And I think getting other patients connected to ways that from the advocates that are already in the space is a really good way to help move that along and get them connected to these systems, as well as finding those champions, like finding the champions who are open-minded, that can kind of have some of the conversations and dialogue, as well as like, I mean, I learned so much from just watching videos. I watched a lot of conferences, like the Kidney Cancer Symposium, Kidney Can, all of the nonprofits oftentimes will post videos of their symposiums and these talks and everything that are happening. And I think when you can learn enough that you are speaking the same language in many ways, it enables those conversations and enables collaborations, enables ways for there to be natural crossover, to be able to not just turn it into patient advocacy of an awareness, but also like, how can we move change together or move change forward together, like by enabling efforts as well too.
Yeah, I completely agree, and that makes a huge difference. Exactly, patient advocacy, and along these lines, I would say narratives. Even science itself is a type of storytelling. Our minds work through narratives. That's their natural state. And so I'll give you one example. There is this rare head and neck cancer. It happens in the face, called SMARCB1 deficient sinonasal carcinoma, SDSC, abbreviated as such. And it's a rare cancer that was identified about 10 years ago on. And, normally, because RMC, renal medullary carcinoma, the kidney cancer that we're so focused on in my lab, is also driven by this same gene, SMARCB1. I might have been aware about this SDSC, but it was, a sentence in a review article. But then what happened was that in December, there was this meeting amongst, both researchers and clinicians and advocates that are interested in this gene SMARCB1. And then you get a patient advocate from France who, lost her child to SDSC and was sharing this very, very powerful story. It's also on the internet. They have a webpage called SMARCB1 Hope. And whilst he was sharing that story, I just could not contain myself. I felt, oh my God, like we really need to do something about this. Like this went from, again, being, just a sentence in an article to something that was viscerally real. And it happened that, Ritzy Johnson, who is from the Chris Johnson Foundation, she lost her son to renal medullary carcinoma. She was also there. So we made sure, they got connected so that they could talk about advocacy. And then, of course, I connected her with Katie as well to share this idea. But even equally importantly, now through all of this has actually catalyzed both efforts to raise more awareness, make videos. For example, through Chubby Emu, Bernard Su, who has made a video for Katie. He has made videos for medullary carcinoma that really raised the awareness tenfold about RMC and the correct diagnosis. And so now there's going to be a video about that. And now we have identified clinical champions that are interested in this. We've connected them with some of our, research efforts. And yesterday, I got some results on this SDSC, like some biological actual results. And, there was an email sent to me by one of the physicians saying, hey, maybe this is an avenue for therapy. Maybe this not. We need more data, which we are getting, and we will have them by 2025. But this is literally an example of something that, was turned from, a sentence that you just read and then you cite to a viscerally real thing that catalyzed progress.
And that's where, like, when you're saying, like, what can patients do? Like, that highlights the importance to me of, like, patients as partners. And the importance of, for me personally, and part of this, I think, came for me from, like, having such a rare cancer that, like, I naturally was learning about all of the rare kidney cancers as part of it. But I think there's such a wide connection of where kind of the ripple effect happens when a patient shares their story. And especially when they can share it in the background and context of the medical information around it. So like being able to kind of talk to it. And so there's an importance, I think, not only to learn about your own disease, but also to be aware of others. So for example, like the very first webinar I watched when I had just gotten my biopsy before Dr. Msaouel was even my oncologist, like he was on a webinar talking about rare kidney cancers, and it was mostly for RMC. But it had a connection that gave me some information on that chromophobe kidney cancer doesn't respond to immunotherapy as often, which was still in my differential diagnosis. And so that helped me, but that helped me also know about RMC kind of right at the beginning of my diagnosis. And I've followed his research on RMC. And that also meant like RMC didn't pertain to my case in particularly, right? But because I had enough information about it, like I was able to help connect Heather, who I know story was shared through the KCA as well too, because like she reached out to me and I instantly was able to put her in contact with Dr. Msaouel as well too. And so there's this like network of connectivity that I think is important, not just to know about your own disease, but also having this crossover and interlay. You don't need to know in depth, kind of, I think, about every single one, but knowing enough about it that like when these connections and opportunities happen, you can connect people with the right people that are the experts that have dove in deep into that area.
And I think to that point, it's also important to keep in mind that what you know does matter, right? To your point of you might not know everything or a lot, but you might know enough to make a connection. I think sometimes as people, and this is broader, bigger than cancer, right? Like we'll think, oh, we might know this little piece of information, but that's not necessarily valuable because I don't know everything. So I'll keep it to myself. But I think when it comes to advocacy, particularly around cancer, even that little piece of information, right, is enough that you can pass on and can change someone's life. We only have a few minutes left. So before we go, I did want to give you, Doctor, a chance to talk more about the work that you're doing in your lab. It's fascinating, especially around rare cancer. So please share more about what you're doing in your lab.
We had a very nice recent conversation with Katie and Msaouel from the KCA about how can we generalize what we're doing for renal medullary carcinoma, RMC, and extract certain principles that can be used for other rare tumors and common ones. Because I think that there are various lessons that can be learned, and in fact, that's what we're trying now to apply to that head and neck cancer SDSC, and it seems that at least some of these principles are working. And so the first key thing was, okay, how can we develop a pipeline, an approach which includes both an approach on how we look at data that is very, very efficient, because when you're dealing with a cancer like RMC that afflicts a vulnerable minority, mainly young individuals of African descent, in the US, they're African American, so they're often underserved, under-recognized, essentially zero funding when we first started. You have to be efficient. You have to be like, okay, every single penny, every single resource, every single thing I'm given, it has to be extremely efficient and put to good use. And to do that, we had to prioritize things like data science. How do we look into data? You will see on Twitter now, called X, there is a retweet of some of the data I put yesterday where somebody caught this. He's a pediatric oncologist himself, and pediatric oncology, is rare by definition. So they deal with rare diseases by definition. He caught it. He said, the key thing is accurate statistical principles, how you look at the data. So we addressed that. We were able to notice certain statistical and data science principles that are coherent and work. And we're teaching them, we're communicating them to everyone, and they apply to across all of medicine, etc. And we started using this along with, in my lab, developing cell lines, which is, cells that we take from cancer and we culture them, and then we may implant them into mice, or we may make the mice develop these rare cancers, and then we use these models to test, do experiments to learn, to gain what we call causal knowledge. We call these functional experiments. That, at the same time, is combined with what we call profiling. So we take the cancer tissues from patients and we analyze it through multiple ways. We analyze its DNA, we analyze its RNA that then turns into proteins. We analyze its what we call metabolic profile. How does it consume glucose, for example? How does it do all of these things? And to try and understand a little bit more about what's happening under the hood. And then we use the models to do experiments to see if we can change things in a positive way. And through all of this, again, with the overarching data science principle, we want to understand both what causes cancer. So we are identifying risk factors for rare kidney cancers like RMC, and that can help also inform approaches to for screening and potentially even for prevention, which is extremely important. But even more important, because these are the patients that I see in my clinical practice, as I told you, narratives are important. So what I encounter really fuels my passion is the patients that need urgently therapies. So patients with, often stage 4 disease, they need new therapies. So a lot of the work that we do is all about identifying new therapies. And we do this through at least 2 strategies. So again, we're very efficient. We follow the most efficient path to get things to the clinic, to actual patients. And so one strategy is if we find that there are drugs that are already on the market, the companies may not be that interested in, funding a trial because trial takes a long time to make. It's feasible. We've done it, but it is, it takes a lot of resources. We repurpose the drugs. We talk with the peer-to-peers, the oncologists on the other side. You learn how to communicate, advocate for this, exactly as Katie said, provide the data, you repurpose, you generate the data, you publish them, you put it on the guideline. Now you have new therapies from where you had none. And the other path is if you have something that is a new therapy that is not on the market, it's not FDA approved for anything, and you think has a lot of potential, you work with various stakeholders to turn them into clinical trials that if they work, then this can be another new therapy for patients. And importantly, and this is a key thing, we strongly believe that in science, most of the times, when we do things, we're going to get negative results. We're going to get the unexpected results. Very often people see all the positive, now they see the renal medullary carcinoma, curves getting better. But that all comes from a lot of what we call failures. And those failures, those negative experiments, they're not bad. They're actually useful, potentially even more useful than the positive ones because they're surprising, and surprise is information. The very definition of information is surprise. So we're ready for the so-called negative experiments. So every single thing that we do, that's all about efficiency, moves us forward constantly.
Well, thank you for all of that. Now, wrapping up, I want to know that perfect segue to what's next. And Katie, you can start on this one. Let the listeners know, what your prognosis is now and kind of what's next for you and your journey.
I think what my prognosis is all my physicians' least favorite question. I think it's kind of that's a difficult question to answer just because of how rare my situation is. But I am in a good place and have been in a good place. I currently have no active cancer, and so. For me, I've switched a lot of my focus on advocating and giving back now. So I work at the Rare Cancer Research Foundation now, where kind of help move research forward for patients with rare cancers. One of the big motivators for me joining them was they have the ability to get tissue from any hospital kind of in the country. So sometimes more community hospitals where patients may be having their surgery may not study chromophobe kidney cancer, for example, if you have your surgery at a local hospital. So that tissue that Dr. Msaouel was talking about, where they create the models and they put them in the mice and are able to drive research and treatments from that. When you have your surgery at a community hospital, a lot of times that research doesn't get done from that kind of tissue. And so what the Rare Cancer Research Foundation and Pattern has is they have the ability to a lot of that research you have to do when the tissue is still fresh. So like right out of surgery, they can, Pattern sends a kit to those hospitals that allows them to get a small piece of that tissue and then send it directly to a lab or an institution studying it. So for chromophobe kidney cancer, we do actually have that set up for chromophobe and all of the rare kidney cancers. Those go to MD Anderson currently. And so when patients are about to have a surgery, they can donate part of their tissue. It gets overnighted to MD Anderson, for example, and then all of this research can kind of go down that path of exactly what Dr. Msaouel was just talking about. And so that's kind of what my focus is really these days, is just working with the Rare Cancer Research Foundation, as well as COA, the Chromophobe and Oncocytic Tumor Alliance that I started for chromophobe kidney cancer, and focusing on trying to help move research forward and treatments forward so that more patients can find themselves in the position that I am currently. So it's kind of my focus these days.
Well, thank you so much, both of you, for joining me. Before we go, Katie, let everyone know when your book actually drops in November.
So it comes out November 12th, but pre-orders are out currently. And pre-orders actually help the book the most because all pre-orders for the book count towards the first week of sales, which is what they use to help determine like how many copies to stock and how much to promote it. And I'm donated my book deal, and I'm donating all my proceeds from that book back to research as well too. So any support there definitely helps.
Awesome. Well, thank you so much. I hope you both have an amazing day.